Hello, my name is Maximillian Pfau from the University Hospital in Basel and now the University Hospital in Bonn. And today I have the pleasure with Professor Mariya Moosajee, Professor for Molecular Ophthalmology and Head of the Genetic Service at the Moorfields Eye Hospital and UCL Institute of Ophthalmology to present to you today the basics of inherited retinal diseases, and it really should be the most important facts to prepare you for the EBO retina exam. I will start with a brief introduction on the basic concepts that you should recapitulate for the exam, and then Mariya leads to you through typical cases, the types of cases which you mostly could also encounter in the exam. So what are key principles to remember? One key aspect is that there are all types of inherited retinal diseases, and all these terms which you should see on this slide, you should be able to briefly describe in terms of typical symptoms and typical clinical signs that a patient might experience. One group is this group of congenital stationary night blindness. Quite a lot of these patients are actually asymptomatic because they are born like this and they don't have much of a disease progression, so they don't really know. At some point, night blindness becomes evident, maybe at the transition to high school, and then they get an ophthalmic exam and then also an ERG, and then this is noted. Then there's this large spectrum of retinitis pigmentosa, which of course every ophthalmologist knows, where you have progression of visual defects from the outside to the insides of the retina and typically bone spicules. And you can have very severe forms of RP with very early onset, something which would be summarized as Leber congenital amaurosis. And then on the opposite end of the disease spectrum, you have cone and cone rod dystrophies. These are characterized by initially central loss of vision, loss of acuity, and eventual more impairment. Also important to remember that many of these cone and cone rod dystrophy patients, as well as patients with steady state cone function syndromes like achromatopsia and blue cone monochromacy, often complain not only about poor vision, but also very much sensitivity to bright light. So this is another sign in this spectrum. And then, of course, the systemic manifestations like Bardet-Biedl syndrome, Senior-Loken syndrome, and then most often encountered Usher syndrome with the RP and the inner ear phenotype. The other concept, which you should really learn off by heart to quickly recognize it on a pedigree, and that's almost a question you can 100% prepare for because it will always come in some form. You should be able to recognize the inheritance patterns. Typically questions around autosomal recessive disease. They will be either asked, like you can see here, in a family where typically a certain percentage of the offspring, 25%, are affected, or the other way they are asked for is if you have a family with consanguinity, which is the most common risk factor for autosomal recessive diseases. Then autosomal dominant disease, where you have affection in 50% of the offspring across 3 generations to prove it. And then X-linked diseases, where you have males affected and then females that are either asymptomatic or have a mild carrier phenotype. The other part, which is kind of important, always if you get shown a clinical image with a clinical description, try to use terms which are related to the disease manifestation, like LCA, retinitis pigmentosa, or on the other end of the spectrum, more like macular dystrophy or very central bullseye maculopathy. If you get presented an ERG, then try to use the ERG terminology. For example, for RP, then use rod or rod cone dystrophy, depending on the exact ERG, or macular dystrophy if you see that the full field ERG is normal, but the pattern ERG is abnormal. And then it's also important to recognize that one gene or one specific genetic disease can cause several types of ERG phenotypes. For example, ABCA4 retinopathy can cause all these ERG phenotypes that are always also used for this lowest classification of 1, 2, and 3. And then you also can use them to describe them clinically. So this 1961 mutation in ABCA4 typically results in this bullseye maculopathy, very macular center focused, and then other more severe form of Stargardt disease can also end up with a cone rod dystrophy in the ERG and then also show a like generalized dystrophy phenotype in imaging. Likewise, for example, RP65 retinopathy can cause all types of disease severities ranging from LCA to retinitis pigmentosa. And then also it's important that, of course, some disease manifestations like this isolated bullseye maculopathy can be caused by several types of genes, could be ABCA4 gene. It's important to know that because that's autosomal recessive, but it can also be caused by PROM1, which would be an autosomal dominant disease, or even by non-hereditary diseases. And the other concept which you should be aware of this is this therapeutic principles and when can you apply what therapy. For RP65 gene therapy, there's this very special case that RP65 mutations, they cause a severe loss of function, but the retina remains mainly intact. And that's why it's a perfect disease for gene replacement therapy, because if the outer nuclear layer is intact and you bring in the healthy gene again, and the visual cycle works again and vision can be restored. In other types of retinitis pigmentosa, the type of degeneration and retinal thinning is much more severe. And then newer therapies, either retinal prosthesis or optogenetic approaches, which are increasingly becoming available in clinical trials, are probably more futile in the future once they become available. Then also in terms of visual function assessment in IRD patients, you should be able to describe accurately the photoreceptor topography. In the fovea and the central 300 microns, you have predominantly only cones. And then once you go outside of this cone-rich fovea, rods start to kick in. And then it's also important to recognize that already in the mid-peripheral and peripheral macula at 5 and 6, 7 degrees, then already rods start to dominate. The most common functional test for inherited retinal diseases, at least for the baseline exam, is of course the ERG, the electroretinogram. 2 electrodes are mostly used clinically, either the DTL wire electrode, because it's more comfortable, or the Brewer and Allen contact lens electrode, which provides slightly more reproducibility. And then you should be able to name the ICEF standard as a standard for clinical electrophysiology. Then there are some more or less fun facts, but they are important to clinically know. So if you look actually at the cone topography, you see that the cone density in the center of the macula and the fovea is extremely high. However, if you compute the whole area or the whole volume under this cone density and compare it to all the cone density outside the macula, actually the absolute number of cones outside the macula is larger than the number of cones inside the macula. And this actually causes an interesting phenomenon, and that's that actually macular dystrophies typically do not show abnormal values in the full field ERG because the extra macular cones, there are sufficient of them to keep the signal high. And that's if you really want to diagnose an isolated macular dystrophy, you cannot rely on the full field cone ERG. You actually need a pattern ERG or a multifocal ERG. Then you should also be able to name for the ERG the sources of the signal. So for the photoreceptor outer segments, they cause the A wave, and then the signal from the bipolar cells causes the B waves. And importantly, that's also a fact you should be aware of, that for the dark adapted or the rod ERG, it's transmitted through the on bipolar cells, whereas the cone ERG both has an on and an off bipolar cell component. And you should also be aware of the ICEF standard ERG and what they are actually looked for. So the dark adapted rod ERG is ideal to identify subtle forms of rod dysfunction, for example, in very, very early retinitis pigmentosa stages. Then the dark adapted bright flash ERG or the mixed cone rod ERG or the DA3 ERG, depending on the nomenclature in your hospital, is especially helpful in identifying electronegative ERGs, because then you can see the B wave, the A wave, which pulls it to the negative, and then the lag of the B wave, so then the ERG stays below this 0 line. Then the cone ERG is useful to identify the cone dysfunction and also helpful to identify complete congenital stationary night blindness, where you have isolated loss of the on pathway, but the second part of the B wave from the off pathway is still intact, or incomplete congenital stationary night blindness, where both the on and off pathway are affected. And then last, the cone flicker ERG, which is most helpful if you want to quantify cone function over time in a really isolated manner, and also for uveitis diagnosis. So this is my first part, and now it's my pleasure to transition you over to Professor Moosajee for the clinical case examples. Thank you.
Thank you, Maximillian. That was a really, really thorough introduction. So thank you all for joining. I am going to start off with some cases. So let's move to the first, just another brief overview. So inherited retinal disorders are the commonest cause of blindness amongst working age adults in the UK and the Western world. They have a prevalence that ranges from 1 in 3,000 people. So far, there are over 360 plus genes that have been identified to cause retinal and macular dystrophies. And if we undertake genetic testing, a patient has a 70% chance of getting that molecular diagnosis. So for me, genetic testing is paramount. And depending on where you are in the world, it may be a retinal gene panel, a targeted gene panel, which is based on exome sequencing, just looking at the exons within retinal disease genes, or it could be whole genome sequencing. And now we're also moving on to long read sequencing as a newer test that may increase our molecular diagnostic rates even further. Maximillian mentioned that we have one approved retinal gene therapy, vormatrigine neparvovec, or Luxturna in the US. And this is targeted at patients with biallelic mutations in the RPE65 gene. And there are a multitude of clinical trials coming through, lots of preclinical work developing treatments for these conditions. So I can't emphasize enough the need to get a molecular diagnosis for our patients. So case 1, this is an 11-year-old Caucasian girl. She developed her symptoms from just 6 months of age. She had nystagmus and digital eye poking. She had a worsening of her peripheral vision and nyctalopia in her childhood. She has no other systemic features, no family history, no consanguinity. Her best corrected visual acuity was 0.5 in her right eye and 0.6 in the left eye. So this is just images of her right eye. Both the right and left eye were very symmetrical. What you can see here in the color fundus image is nummular pigmentation, which is widespread across the retina. If we look at the autofluorescence image, we can see an area of hypoautofluorescence. But if you look very carefully, there is some preservation of para-arteriolar sparing around the RPE. If we then look at the OCT, we can see a thickened OCT with a lack of retinal lamination. And I've just put a normal OCT just to compare that. So based on the history and the images, I would just like to ask the audience to put in the Q&A what they think this condition could be and what they think the gene causing it could be. So I'm just going to give you maybe 15 seconds. If any of you want to just hazard a guess. So you just have to click on that Q&A button. Okay, some good guesses. Two people have guessed RPE65. So I'm just going to move out of that. How do I get rid? There we go. So we did genetic testing. I will say, just on clinical examination, it isn't RPE65. There are some characteristic features of RPE65. First of all, when you've got RPE65 causing Leber's congenital amaurosis, the child will not fix or follow from very early on. They can have the nystagmus, but they have something called photoattraction. They love looking at bright lights, at the sun. And when you do imaging, and if you do a fundus autofluorescence, you will have a characteristic sign of no autofluorescence. So that's how we know with these images, it's not RPE65. So I'm going to go to the next slide. So we did genetic testing, and we found that this patient had two mutations in the CRB1 gene, the CRUMS1 gene. They had compound heterozygous mutations. So you can see the two mutations here, one affecting exon 7 of the gene, and one which is a splice site mutation just ahead of exon 12. So CRB1 related retinopathy, in this patient's case, it was Leber's congenital amaurosis, and this gene accounts for 17% of patients. The characteristic feature of CRB1 Leber's congenital amaurosis is a thickened retina with loss of that retinal lamination. So if you ever see that or hear someone saying a thickened retina, think of CRB1. It's inherited autosomal recessively, but this gene actually gives rise to several other phenotypes. Aside from the Leber's, it can cause retinitis pigmentosa, a cone rod dystrophy, and a macular dystrophy. And there are now some emerging genotype-phenotype correlations. For example, there is a common mutation that causes the macular dystrophy phenotype. Less is known about the characteristic variants of these other phenotypes. But we have also just published a certain variant that leads to glaucoma in patients with a cone rod dystrophy when the patient is of African descent. So lots still emerging about this condition. The CRB1 gene is expressed in rods and cones and in the Muller cells, and the gene itself is found in the tight junctions, and it has a role in apical basal polarity. So it's involved in how the retina forms, how the cells within the retina proliferate and differentiate. In animal models, when you knock out CRB1, you get an increase in cell proliferation and a reduction in cell differentiation. And so it's thought that that thickened retina is due to that increase in cell proliferation in early stages of embryogenesis, and actually a lack of those cells going on to differentiate into photoreceptors, bipolar, and ganglion cells. There are genetic therapies underway in development. So a team in the Netherlands are developing AAV gene therapy. Our group in London are developing mRNA therapies. So there are no clinical trials at the moment for this condition, but obviously watch this space. And as you should know, if you're looking for any clinical trials on IRDs, it's always worth looking at clinicaltrials.gov. Okay, so case 2. This is a case of a 27-year-old Pakistani Asian woman. She noticed a gradual drop in her central vision in the past 4 to 5 years. She's generally fit and well, and her best corrected visual acuity on Snellen is 6/36 in each eye. There's no family history of any ocular disease, but there is consanguinity. The parents are second cousins. So again, this is her left eye, and the left and right eye were both quite symmetrical. So on the fundus imaging, you can see an area of macular atrophy, of RPE change. There are no obvious flecks, though, around the macular region, and the periphery looks quite healthy. If we look at the autofluorescence image, we can see right at the center, the foveal macula, there's a large area of hypoautofluorescence, which accounts for her poor vision. and this is extending outwards, and there is an area of a hyper autofluorescent ring around that lesion. And if you look at the OCT, you can see complete loss of the ellipsoid zone in that central macular area. So we're going to try polling again. Before I tell you what the result is, I would like you to try and, again, guess what the condition and what the gene may be. I've just clicked on and I've just seen that, Monica, you guessed correctly on CRB1, by the way. So well done to you for the last question. So any guesses? Any guesses on what this could be, what this condition could be if you see them in your clinic, and what the gene may be? Okay, so definitely a cone dystrophy, correct? Or I would call it, so cone dystrophy is more the ERG description, would be more of a macular dystrophy. Well done, Monica. You're excelling at this. So she's guessed ABCA4 retinopathy. So let's have a look. So we did genetic testing, and absolutely we found homozygous missense mutations in the ABCA4 gene. And this is the variant that we found for this patient. So ABCA4 retinopathy, also known as Stargardt's disease. And I want you to remember Stargardt's because it is the most common inherited macular dystrophy. And at least at Moorfields Eye Hospital, it is the most common inherited retinal disease that we see in our IRD population overall. So it has an autosomal recessive inheritance when it's caused by ABCA4. There are rare cases where you can get PROM1 mutations. And this has an incidence of 1 in 8,000 to 10,000 people globally. And you can see in the image what we call that dark hypoautofluorescence area is a definite decreased autofluorescence. And then surrounding it, you have these hypoautofluorescent flecks. And surrounding those, you have hyperautofluorescent flecks where the cells are starting to degenerate. And in most cases, you can sometimes see those retinal flecks on fundus examination. So the ABCA4 gene is an ATP binding cassette transporter subfamily A4 gene. The protein is expressed in our rods and our cones, and it's involved in the visual phototransduction cycle and in vitamin A metabolism. So the gene the protein facilitates transportation of phototransduction waste material from outer segments of the photoreceptors to the RPE. Now, mutations in this gene lead to an accumulation of that lipofuscin containing toxins like A2E in the photoreceptors and the RPE cells, which result in RPE dysfunction and RPE loss and photoreceptor loss. Electroretinography is actually really important for Stargardt's patients. The pattern ERG is usually abnormal. Patients can be divided into 3 groups based on these initial full field ERG findings. So there's group 1, 2, and 3. Group 1 is where you have normal cone and rod responses, and there's really isolated macular dysfunction. Group 2 is where you have abnormal cone but normal rod responses, and this is generalized cone dysfunction. And then group 3 is when you have abnormal cone and rod responses with generalized retinal dysfunction. And this classification can serve as a prognostic indicator for the rate of disease progression for these patients. So all patients in group 3 will have significant ERG and visual deterioration over 10 years, whereas those patients that fall into group 1, only 22% will have a similar progression. So if you do an ERG on a patient with Stargardt's ABCA4 and they fall into group 1, you can give them a prognostic indication that their disease will be milder compared to those that are in group 3. There are several trials underway for Stargardt's. This is just, a few of the ones that are standing out. So we've got oral treatment tinlarebant, oral metformin, oral ALK 001, intravitreal Zimura. These are all drugs that are focused on reducing the toxic effect of vitamin A in the retina, or delivering a synthetic form of vitamin A so that the retina can utilize it in a safe way without it building up and causing toxic effects. And there is a new dual AAV gene therapy trial, which is underway in the US and is coming to us in Europe very soon, called SB007, run by Splice Bio. And essentially, the ABCA4 gene is too large for a standard viral AAV gene therapy. And so what they're doing is splitting the gene in two, adding inteins and delivering it as a dual AAV delivery product. And then within the cells, the two parts of the ABCA4 gene will join together so that you can form a normal healthy protein. So that's the principle of that. Good. So that's the end of my cases. I think myself and Max are just going to have some discussion.
Thank you so much for those 2 cases. And maybe I start with the first case beforehand. So if you have a patient with central atrophy of the retina and then pisiform flecks outside, you're not sure if it's real Stargardt's disease or Stargardt-like disease, and then you take the blood draw for the genetic testing. What do you recommend them in terms of diet until the next visit or overall for their lifetime? Do you comment on smoking, UV protection?
Yeah. So, okay. So the first thing is to ask if they're taking vitamin A supplements. Number one, about 30, well, no, it's longer than that now. Say 60 years ago, when they identified that vitamin A was central to the visual cycle, there was a vogue for people to prescribe vitamin A to IRD patients. And back then, more or less everyone was just called retinitis pigmentosa. There was really no differentiation of all these different types. And then what was found is that a subset of patients actually lost vision when they were taking vitamin A supplementation. And now we find out that it was the Stargardt's patients, the patients with ABCA4 mutations. The fact they have a mutation in this gene means they cannot break down the vitamin A safely. And so they end up with a toxic buildup of its byproducts. And so we have to advise our patients not to take vitamin A supplementation. I follow on to say I recommend a healthy, balanced diet. So for any IRD patient, actually, as it goes, they should have green leafy vegetables and fruit, particularly fruit that is rich in antioxidants. So fruit that is red, blue, and black in color is very good for them because it has high levels of antioxidants. And we base that on the fact that in all our work, we have seen high levels of oxidative stress in the retina of IRD patients. So this helps to neutralize it. And there are trials at the moment for high dose antioxidants for RP patients. So we have to await the results of that. Absolutely, smoking should be avoided in all patients generally because it obviously worsens the retinal conditions. We know it has a link with AMD, but also with IRDs. And then they should wear UV protected sunglasses in bright light. They should exercise regularly. And I also go one step further to advise my patients to use a blue light screen protector on their devices. Although there's no proven evidence, we do know that blue light does cause harm. And for a lot of these patients, they're holding their mobile phones or devices really close to their eyes, constantly, magnifying the view. And so having that blue light screen protection will really prevent that constant light stimulus.
Okay. And thank you very much. Then maybe for the other case, for the CRB1 case, it's obviously an early onset type of dystrophy spectrum overall. What is, in your opinion, also important beyond just the medical workup of the patient in terms of preparation for school, low vision aids? What should people be aware of?
Absolutely. And Maximillian, in fact, we did ask some of our candidates last year this in the exams. This is really important to understand this. But, you know, when you have even a baby that is presenting with an inherited retinal dystrophy, you need to be thinking about their future. At least in the UK, we will site register them so that they can get access to all the support they need from a social care perspective, but also support in schools. They get access to qualified teachers of the visually impaired to help them from nursery onwards through their education. They can get introduction to digital technologies. If their vision deteriorates and gets worse, they can get access to Braille teaching, to guide dogs. We need to make sure that these patients are constantly reviewed in low vision clinics in the hospital, and that we provide the right counselling for the family support, counselling for the parents, because it can be very, very difficult for the parents to cope with these kind of diagnoses as well. Max, do you have anything else that you want to contribute to that?
No, I think that's the key important point for the exam. And myself, I've worked in Switzerland, I've worked in Germany, so the workflows of how to refer patients in both countries are quite different. But everyone that takes the exam should be at least be aware for his country to say, okay, these are the patient organizations I need to refer someone to. Beyond the patients' organizations, these are the legal or government-based institutions where you also can refer someone to get additional aids. So that everyone who prepares for the exam really should work up on how to refer low vision patients. And of course, we understand that it varies by country. Myself, I'm only aware of France, Switzerland, and Germany for the details, but you should be aware of your own country in that sense.
I just want to also just add that 30% of IRDs are syndromic. So when you're presented with a child, you know, history is key. And the examination is key. It's not just looking at the eyes, it's looking at the individual as a whole. And if you have any suspicions or you're worried, always consider referring to a pediatrician or clinical genetics so that they can just exclude if there is anything else. And obviously, if you are undertaking genetic testing and it comes out with a syndromic IRD, that will obviously guide you as to who you need to refer to. But clinical genetics is a really good central point because they will coordinate all the care for pediatric patients.
Then I think it would be a good timing to go to the next two cases.
Yeah. Okay, so this is a slightly more intense case, I would say. So this is a 7-year-old boy that I actually saw. He had a 6-month history of rapid progressive loss of vision involving his peripheral and central vision. Now, when I say rapid progressive loss, he had absolutely normal vision 6 months prior to me seeing him. He had had optician checks, optometry checks. His vision was 20/20, logMAR 0.0. But within 6 months, his presenting vision was 1 logMAR in each eye. There was no past medical history. Parents had no other concerns about him systemically, his cognitive function, no developmental delay, anything like that. And no history of any consanguinity or other family history. So on examination, this is the fundus appearance. There were no obvious retinal pigmentation or atrophy. There's some mild arteriolar thinning. Fundus autofluorescence showed a hypoautofluorescence at the fovea and a kind of a surrounding ring around the macula in the mid-periphery, but nothing hugely striking. There are subtle signs there. So I'm going to just pause there and I'm going to ask you, what are you thinking at this point? So pop it in the poll for me. Hina, well done. You said Stargardt's last time. So for this patient, what would be your top concern here? or your differential list. The key things to think about is that rapid loss of vision over a 6-month period, from being completely normal, unaffected, to 1 logmar in both eyes. Okay, so nothing's coming up yet. I'm just going to keep going because I've realized that my next slide is just the OCT. So the OCT, as you can see, shows outer retinal disruption with outer nuclear layer thinning, loss of the ellipsoid zone, it's broken up there, and then these kind of weird corrugated macular stria folds. We did electrodiagnostics and we found electronegative ERGs with inner retinal dysfunction. So I'm just going to check because I've seen there's a couple of things. So, okay, so there's some good ideas here, but this is why I wanted to include this case. So what we are querying here is something called Batten's disease, also known as juvenile neuronal ceroid lipofuscinosis, one of the NCL disorders. And so this is an incredibly important differential to have when you have a child that has very, very fast retinal degeneration over like that 6-month period. You have to actually act faster than just doing standard genetic testing. So in this case, we took a blood sample and we sent it off for light and electron microscopy. And this was to confirm the presence of these vacuolated lymphocytes. And we specifically tested for one of the genes that causes the juvenile form of this condition, which is CLN3, and the patient was found to be positive. But until you have done these 2 tests, I urge you all not to write Batten disease on any letter. Just put rapid retinal degeneration under investigation. We had this particular case was referred to us from pediatric ophthalmology, and the doctor wrote query Batten's disease on the letter. The mother then Googled this condition and went into overdrive because it is a lethal condition and causes premature death. And I'm going to talk about it a bit more, but just, you know, if you're worried about this, don't write it. You can talk to your colleagues about it. You need to find out your local protocols. There will be labs who'll be able to test for this, but it's something that you shouldn't mention until you're absolutely certain, because it can cause a huge amount of anxiety and stress. So as I mentioned, it is a devastating group of inherited neurodegenerative disorders that primarily affect children. The clinical phenotype depends on the specific subtype. In this case, it was juvenile CLN3 Batten's. That usually presents between 4 to 7 years of age with rapid visual loss. What then happens is that child essentially goes into early dementia. So they have reduced cognition. They start to develop seizures, which can occur about 3 to 6 years after the vision loss. They get impaired motor skills in their mid-teens and then premature death in their mid-20s. So I wanted to highlight this as, you know, a case where it is urgent. We have to tread carefully and be very sensitive, but also always be aware of that rapid visual loss in a child. And this is just an article on the first-in-man study of this intravitreal for an infantile form of Batten's, which is caused by CLN2. Okay, I can probably move to case 4. So this is a more gentle case for you guys. It's my last case. So this is a 20-year-old Caucasian female. She actually was born with moderate sensory neural hearing loss. She wears hearing aids for this. And she recalls experiencing difficulties with her night vision from the age of 16. And then she complained of gradual peripheral field loss. No family history, no consanguinity. So this is her Optos color fundus images of both eyes. And here you can see there are some bone spicules in both eyes in the mid-periphery. I would say there's retinal vessel attenuation in both eyes. This is the fundus autofluorescence. And you can see the hypoautofluorescence in the areas of that bone spicule. But at the center, at the macula, you can see that really bright hyper autofluorescent ring, which is characteristic of retinitis pigmentosa. So this is a very characteristic RP phenotype that we see. So this is the OCT. And we identified that the patient had bilateral cystoid macular edema. So we know that this is on the background of RP. So we promptly started the patient on AZOP 3 times a day in both eyes. It could also be TrueSopt. And myself and Max can talk about our approaches for treating CMO in a moment. But we went on to do genetic testing. So what do we think we are considering here for this patient? I think people have already said it. Wonderful. Okay, yes, absolutely. So the key differential here is Usher syndrome. And so we did genetic testing and we found compound heterozygous changes in the USH2A gene. Now, the USH2A gene is the commonest gene that causes type 2 Ushers. And actually, it is the commonest gene that contributes to all Usher cases, type 1, 2, and 3. And this patient has these 2 mutations. One of them is actually the most common mutation seen in USH2A patients. So it's 2299 deletion. And this is situated in exon 13 of the gene. It's a mutation hotspot in this gene. And actually, this second mutation is actually very common in the Slovenian population. This is actually a founder mutation from Slovenia. So as I mentioned, it's the commonest gene to cause type 2 Ushers. Now, the protein usherin is actually expressed in these ankle links of developing hair cells. So if you can see my hand, if you can imagine they're the hair cells in the ear, you get these links forming between them in utero. And those links form so that your hair cells grow in the proper conformation. But when it's not present, those ankle links, because of the lack of usherin, the kind of hair cells end up not forming correctly in a correct configuration. And it's that structural defect of the hair cells that cause the sensory neural hearing loss. The gene is also expressed in the periciliary complex of the connecting cilium in our photoreceptors, and it acts as a docking site. So, for example, at that connecting cilium, rhodopsin is formed in the inner segment of the photoreceptors. It's then shuttled to that connecting cilium to the docking site with usherin, and then it's shuttled up into the outer segment in the area where it works. And so if usherin isn't there, it doesn't form the correct docking complex with whirlin and ADGVR1, 2 other genes that cause type 2 Ushers. And the rhodopsin stays localized in the inner segment, causing a lot of congestion, which then goes on to lead to photoreceptor stress and then death onwards. So you get this sensory neural hearing loss from birth, and then the RP in type 2 Ushers usually manifests in adolescence. And often you'll get a history of individuals noticing night blindness when they're going to the cinema with friends, or sometimes later on that they're driving and the passenger is feeling unsafe because they're missing cars or motorcyclists or pedestrians from their field of vision. That's also a common complaint that we hear. I mentioned the common mutation, the 2299 del in exon 13. And the reason I mention this is we have a phase 2 clinical trial at the moment using an antisense oligonucleotide, which is basically a string of nucleotides that can bind to the splice site of exon 13 and just cut it out of the RNA. Now, this is a really big gene, USH2A. It's about 16,000 bases in length, and it has 72 exons. And so essentially, this therapy will cut out exon 13, and so it will leave a 71 exon protein, and it skips from exon 12 to 14. And that 71 exon protein is thought to have enough function to prevent further degeneration. But that trial is underway. And so it's important, therefore, again, to have that genetic testing. And it's also just important to know that mutations in USH2A also cause about 20% of non-syndromic RP. So it's not always just found as part of Usher syndrome. It can actually cause isolated RP as well. Before we go on to the discussion, I did just want to leave you with a bit of reading material. This is a really good review because I wrote it, but we actually hand this paper to every fellow that starts our clinics, and it's a really nice explanation on how to undertake genetic screening, how to interpret genetic results. So I urge you to read this. It's a very useful guide for you. And then this website, gene.vision, which is a website that, again, I created at Moorfields with the funding of the National Institute for Health Research and Retinal UK. But essentially, it's a completely accessible website, both for patients and professionals. So, for example, if you type in Usher syndrome, there will be a page for patients and there will be a page for healthcare professionals. For us, it will be in language that we understand, but for the patients, it will be fully in lay language. There's also Google Translate, so it can translate the pages into every language you could look for, but it gives you information on the condition, on those support groups, on the current research, any clinical trials, information on inheritance, on pre-implantation genetic diagnosis, anything to do with genetic eye disease. It's an A to Z compendium. So if you're sitting in clinic, and also you get a genetic result and you want to type the gene in, you'll get a lovely gene card with all the information so you can look like an expert when you're explaining results to patients. So just to conclude for this presentation, IRDs, and I think that was actually really exemplified by Maximillian's initial presentation. There is huge genetic and phenotypic heterogeneity. And yes, we can kind of guess what the gene could be. We have an idea, but actually, you know, it's safer to actually undertake genetic testing and make molecular diagnoses. And also, we're starting to move away from calling conditions retinitis pigmentosa or Stargardt's and actually calling it ABCA4 retinopathy or USH2A retinopathy, because it makes that condition more accessible, both from a research, clinical trials and treatment perspective, for genetic counseling, for, as I said, access to family planning. I can't emphasize enough detailed history taking and careful phenotyping. You can make 90% of your diagnosis based on the history. Undertake genetic testing, allow patients that access to treatments, clinical trials, to the research. Getting a result allows us to assemble the correct multidisciplinary team to optimize patient care, to reduce comorbidities, and it allows our families to access family planning, understand about their risk of having more children, how it happened in the first place in terms of inheritance patterns. So I'm going to acknowledge my team. If any of you have any questions or want to get in touch, my email address is there. And thank you, Maximillian, for inviting me to speak today. So Max, I think we're going to have a bit more of a discussion on those last two cases.
It looks like his internet connection might have failed. He just left.
Oh, okay, that's fine. I can handle it.
Perfect. Let's see if he comes back in a second.
Yeah. So I can see like you've all put lovely guesses and a lot of you were correct. Do any of you have any questions for me that you'd like to put in the chat that I can help answer? So maybe I'll just talk a little bit about the family planning side of things while questions may be coming. Getting a genetic diagnosis now means that we can accurately provide genetic counselling to patients. As I said, we can explain why this happened. One of the two big questions that I have from patients is what caused this and is there a treatment? Now, by knowing what causes it, so we can explain that to them. But if you have two parents that have an affected child and you can identify whether this was inherited from them or if it happened de novo, sporadic, just in the child, so when they were a ball of cells in the womb, you can also reassure the parents that they can continue to try to have a family and they won't have more children affected by this. Or if they have a risk of passing it on, what that risk may be. There is something called pre-implantation genetic diagnosis now available. So this is a form of in vitro fertilization or IVF. If you know the genetic cause of your condition, you can take the eggs and the sperm of the parents, fertilize it, and when it's a ball of cells, you can take a cell and you can check to see if it's carrying the mutation and then only implant healthy embryos back into the womb. So this is a way of not passing this on to future generations. And that is, at least in the UK, a part of our National Health Service. So that comes as a free service. And even for people who don't want to have an IVF, there are things called non-invasive prenatal testing where you can get pregnant naturally. And then at around 8 weeks, you can take a blood sample and isolate the fetal DNA and see if they're carrying a mutation. And then you can offer them the choice of whether they want to proceed with a pregnancy or not. So I have a question. Welcome back, Maximillian. I was just...
Sorry, I just dropped on the last slide.
That's okay. So we have a question from Eduardo. If a female patient is 35 and found with ABCA4 gene without any ophthalmic symptoms, is it only time until she would develop some phenotypic disease? So I suppose the question is, why was she found to have the variants in ABCA4 in the first place? Was that incidental testing for something else? There are patients that present with later onset Stargardt's disease. So I would, if it was a patient that had two mutations that were likely pathogenic, I would continue to follow that patient up yearly, or at least ask them to go to their local optometrist, because the initial signs would be some changes in their central vision. So I wouldn't rule it out if they were absolutely negative. If they were asymptomatic at that stage, you can get later onset cases. And then there is a question for you, Max. Is there any role for N-acetylcysteine for antioxidants?
So that's, of course, a really tough question, because currently the neck attack trial is ongoing. We in Basel take part of it, and many centers.
Yeah, Moorfields is as well, yeah.
Well, and so far from what, of course, we don't know who gets the real compound versus placebo, but so far everyone is doing well. So at least in terms of side effects, it may be tolerable. And I think it's a complex situation. So because a lot of patients ask me for it and they cannot be enrolled in the trial, and they say they want to do something no matter what. What we currently offer them is, we advise against the nutritional supplements because they're usually not regulated, even though they are cheaper. So if someone really, really, really wants to take it no matter what, but is not eligible for the trial, and they already almost announced to us that they will buy the supplement, then we will actually offer them a prescription to get the real version from the pharmacy, just to be sure that what they take is actually what they want to take, kind of. But we advise against it. And the reason we advise against it is that there has been this person trial in Harvard many years ago with high-dose vitamin A and high-dose vitamin E. And the high-dose vitamin E was even damaging in retinitis pigmentosa. And that's always the problem. Until the trial is done, we don't know. I don't know what's your practice pattern around that.
So we obviously work a lot by evidence-based medicine. So until even a trial comes and tells, until it's approved, we wouldn't. That's why for me, it's much more of a, please take your antioxidants through your diet as well. So take those blue, black and red colored fruit that are rich in it. However, I do see the point. There are some patients that are desperate. We can't write a prescription for the N-acetylcysteine in the trial in the UK. I was actually speaking to the coordinator at Moorfields who was running the NACATAC study there. And she did actually say that, for those patients, you could suggest the supplement, but the purest one with the least like preservatives, etc. And actually, the dose that you get in those is about 600 milligrams, which is really quite low. And there are reputable health food shops you can get it from. And, some people take it for other reasons, cardiovascular disease, etc. So my feeling is I don't think it would cause harm at a low dose, but it may not do anything. And there is always a chance it may have a detrimental effect. So but my advice would be dietary. Take the fruit and the vegetables until we hear the results.
And luckily,
interestingly, when I've been to America and listened to some talks from the IRD specialists there to patient organizations, they very freely tell patients to go and buy it and start taking these things. So it's I think very different practice from US and Europe, I think. I don't know if you find the same. So
no, against it. Like our advice is against it, but we are just worried about some impurities in supplements. But yeah. Maybe it's a similar thing where there's, I think, a lot of discrepancy from center to center. So you showed the ASH2A case with a cystoid macular edema.
Oh, yes.
How do you usually initiate treatment for that? When do you stop treatment? What is your thinking about that?
Yeah, so I would always start with the drops first. Initially, just to see if they respond to that. So I would either start them on Trusopt or Azop 3 times a day, and I would then see the patient again in 3 months and repeat the OCT. If they're responding great, that's it, they can continue, and then maybe see them in 6 months, maybe even longer, depending. But if they're not responding, then I would think about considering oral Diamox or acetazolamide. Now, obviously, when they have to take that orally, they need to have regular blood tests. So they would have to go and get their use and ease measured, their bicarbonate potassium levels checked before they start. Then they would be started on, I think it's 250 milligrams twice a day. I think you can start at 125 milligrams as well. And then there's a special dose for children based on kilograms. But then they have to have the blood test every month. I always ask them, just make sure you eat a banana every day to keep your potassium levels up. And as long as the blood tests are within the normal range, they can continue. And again, bring them back in 3 months to repeat the OCT. And hopefully then they would be responding. And then you do come across so then you could start at 125 milligrams, but you can increase then to 250 as well. And then there are some patients that are also on drops and the oral tablets and not responding. And then the question is, then what? Because there's been loads of studies looking at, for example, anti-VEGFs, etc., but they haven't really shown proven benefits. So what do you do, Maximillian?
Quite a similar practice pattern. So we start with Crusob 3 times daily, and we escalate to oral Diamox, usually actually 125 twice a day, and then refer them to their general physician for the potassium and blood checkup. Usually after some time, we also do the inverse test where we stop treatment, because actually from time to time, sometimes a little bit edema comes back, but patients say that they functionally stay exactly the same. And if it's just a little edema, then we would recommend rather to tolerate that instead of
Oh,
thinking.
absolutely. And I should also say, if it's, I mean, the edema we showed, that was gross. So if you've got tiny little areas, I wouldn't then start them necessarily on drops. I may just monitor them, because, you know, a lot of people just, they don't want to. And with the IRDs, the macular edema wax and wane. So yeah, there's a certain point at which then I would consider, but not just for tiny small cysts.
Yep.
Yeah. And what do you do if they're refractive and they're just not responding?
I mean, usually we increase the dose of oral Diamox, but to 250 2 times daily, but then usually at some point we stop. There are some patients which are externally referred to us, and they have an external ophthalmologist giving them steroids, either by injections, even Ozurdex.
Mm-hmm.
To be honest, in my experience, it seems to cosmetically make the appearance in OCT better. I've not yet seen a patient that responded functionally well to steroids. That's why I'm not a big fan of it.
Yeah, I agree. Yeah.
So that's why I advise against it. And then the other thing maybe we talked about is, so what do you consider red flags, and why do you think should be? So you had the Batten disease as one case where maybe a little bit of urgency. What are other signs where you may refer patients more earlier, sooner than later?
Well, so there's always a chance that what you're seeing could be a uveitic presentation. It could be cancer related as well. So these are just, they're the kind of red flags that I would just bear in mind. Also, you know, you can get an idea of these things with the history, even if you just ask what drugs they're taking as well. That could be influencing what you're seeing too. Max, what would you say here?
Yeah, I think in terms of clinics, of course, one thing is this whole spectrum of electronegative ERGs or atypical ERGs. The part on the electronegative ERG is actually, of course, nice for exams because it kind of can be tested quite systematically. I think there the important thing is to be able to recognize the complete congenital stationary night blindness in terms of ERG phenotype, where you have this A wave in the photopic ERG, which is kind of prolonged, and then comes the off signal. And if that's from birth, typically it's like nyctalopine or TRPM1. But if it's acquired in adulthood and the retina looks relatively unremarkable, in OCT you see thinning of the retina, but you don't see much bone spicules, and you have a sudden onset of night blindness and then an electronegative ERG, and questions around that, you always should think of MAR and then recommend referral according to that. Then the other spectrum, which is much more complicated in my mind, is this general late onset night blindness phenotype, because then of course you have this whole spectrum of autoimmune retinopathy, which can also be general cancer-associated retinopathy with very variable phenotypes, both in terms of clinics and ERG. And then there's also, of course, the spectrum of retinitis pigmentosa, sine pigmento, where again in OCT you see the thinning, but phanoscopically you don't see much. And then you have these weird phanoscopic peripheral changes, which can be uveitic, and then that's a kind of a complex spectrum. And there's also interesting there, we had some unsolved cases, but nowadays with whole exome sequencing, then it turned out to be actually just RP. And yeah, there the workup is difficult.
Yeah.
The other treatable issue, which is also part of the IRD spectrum, even though it's strictly speaking not an IRD, but just for the exam purposes, is of course ocular vitamin A deficiency. It used to be really rare, but from time to time now, because of some bariatric weight loss surgery, we see cases which have a vitamin A deficiency acquired. And that's, of course, something which can easily be reversed. So if you see onset of night blindness, but the retina looks quite unremarkable, maybe some SDD, subretinal drusenoid deposits, think of that as well. Yeah. Is there any other red flag or important fact which you would like everyone to remember from today?
I don't think so. I don't think there's anything else.
Yeah. So then this is it for today. Thank you very much. Or maybe I just look into the general question before I conclude. So there's one last question about a drug called metazolamide. We don't use it here in Switzerland. I don't know if you've experienced with this.
We don't either, but that's good to know. So for everyone who's listening, Kirk Stevenson said that in Canada they use oral metazolamide, and it can be effective in cases where Diamox hasn't improved the macular edema, and safe in children, which is good to know. There's a good question on identifying cis or trans mutations for recessive IRDs. So for recessive cases, unless it's homozygous and you know that, you know, each parent has passed on one of the variants, it's always good to undertake segregation. And so ideally you would take a blood sample from parents and check that one has come from each parent, and that they're not both inherited on one allele from one parent, because then that wouldn't be the cause. But if parents are not available, you can also check in the offspring of the proband as well, because the patient would have passed on one of the alleles and the child would be a carrier. So that's just to answer that question. And then I think Monica was asking, how do we counsel patients with isolated IRDs due to variants in genes causing systemic syndromic conditions like Batten's or metabolic disease? So I think, you know, if it's a known variant and you check the literature and you can find that there are precedents for these variants causing isolated conditions, I think you just simply have to explain that to them. If it's a variant of uncertain significance, that's a really difficult situation, because then you don't know, one, is it even pathogenic or not? Is it going to cause a systemic condition or not? And I think when you're always worried in those situations, I would really get clinical genetics involved, because they may know of other ways to work up the patient from the other systems. And then obviously you would continue to monitor the patient as well. And especially in the UK, they, you know, if you actually identify patients with certain systemic conditions, they sometimes feel that the genetic counselors working in eye clinics are not actually sufficiently trained to deal with some of those systemic counseling issues. And so it does make sense to involve those other teams who have a kind of broader knowledge base than us.
Yep.
Okay.
Fully agreed. Then thank you so much for everyone joining today. And then this includes our preparation for the EURETINA EBO exam. And please email us if you have any questions. Thank you.
Thank you so much. Thank you.